Bismillahirrahmanirrahim. I have talked about supraventricular tachycardia and sinus tachycardia in last videos in tachyarrhythmia section, and today I'm going to talk about atrial fibrillation. So let's talk about atrial fibrillation, right? So if we see that most common sustained arrhythmia, right, in hypertensive patients and more than 65-year-old patients and patients of hypertrophic obstructive cardiomyopathy, right? So it is atrial fibrillation, right? If we see the most common arrhythmia in structurally normal heart, that is SVT, supraventricular tachycardia, right? If we see that most common sustained arrhythmia, right? So this is basically atrial fibrillation. So it is most common in hypertensive patient and more than 65 and hypertrophic obstructive cardiomyopathy patients. So most common cause of embolic stroke is non-rheumatic atrial fibrillation, right? So most common cause of embolic stroke is atrial fibrillation, right? So now let's talk about what is the definition of atrial fibrillation. So it is basically a irregular, ineffective, chaotic atrial rhythm, right? That fires at 300 to 600 beats per minute, to which AV node is going to respond intermittently, right? So this leads to irregular ventricular rate, right? That's how we're going to get the irregular pulse in these patients. Let me draw this here. So if we check, this is a left atria, right? So this is the left atria, and here we'll have the four pulmonary veins, right? So we'll have these four pulmonary veins. So around pulmonary veins, most of them these ectopic foci are formed, right, because of dilation of the pulmonary veins. So they fire intermittently. Just say this fires at 300 beats per minute, this foci fire at 350 beats per minute, this foci fires at 400 beats per minute. So firing rate will be different, right? And then AV node will respond to this firing rate. Just say once this was firing, this ectopic focus was firing, so AV node was able to block some of impulses, and just say AV nodal block was 2:1, right? So just say now if we talk about if block was 2:1, so rate will be 150. When this focus fires, right, so rate will be, if AV block is again 2:1, so AV block will be if it is 400, it will be 200, right? So we can see the ventricular rate will be according to AV block. So we have different foci that fire at different rate, then AV node block impulses differently. Sometime it blocks AV node block will be 3:1, sometime AV node block will be 4:1, like that, right? So when we'll have different AV nodal block, so we'll have different ventricular rates. So that's how we're going to get the irregular pulse in these patients. If we auscultate these patients, their heart rate will be more, right, but their pulse rate will be less. So that's why we're going to call that as pulsus deficit, right? That is what we're going to find in these patients, right? So let's talk about causes. So cause is the mostly valvular heart disease patients, like mitral stenosis is one important cause of that. Another important cause is hypertension secondary to LVH, left ventricular hypertrophy, right? So this is important cause. And then we'll have the ischemic heart disease post MI, right? So we're gonna see the atrial fibrillation in these patients. Again, important causes: congestive cardiac failure, constrictive pericarditis, cardiomyopathies, like, and also atrial myxoma can lead to that. Infective endocarditis can lead to that. Then we have non-cardiac causes like pneumonia, electrolyte imbalance can also cause atrial fibrillation, hypokalemia, hypomagnesemia, hypocalcemia, pulmonary embolism, lung carcinoma, sarcoidosis, hemochromatosis, and hyperthyroidism. So these are the hyperthyroidism can also cause the atrial fibrillation, right? So sometime it is idiopathic, right? So we're going to call it as lone AFib. So if it occurs in young people and we don't find any structural abnormality in the heart, so this is called as lone atrial fibrillation, right? So this term is not used anymore, right? So it is mentioned in textbook of cardiology. So we have actually various types of atrial fibrillation. So one is called as paroxysmal atrial fibrillation. Paroxysmal atrial fibrillation, if atrial fibrillation terminates spontaneously within 7 days, we're going to call it a paroxysmal atrial fibrillation. So we have got two types of that. One is called as vagotonic atrial fibrillation, and another one is the adrenergic atrial fibrillation, right? This is about the paroxysmal atrial fibrillation, right? So if it remains for more than 7 days, right, so we're going to call it as persistent atrial fibrillation, right? Persistent atrial fibrillation if it remains for more than 7 days but less than 1 year. So if it remains for more than 1 year, we will call this as long-standing persistent atrial fibrillation, right? So these are the types of atrial fibrillation. So now let's come back to our discussion, right? So I was talking about this thing. So alcohol intake can cause dilated cardiomyopathy, right? So it basically will have the multiple foci in left atria, right, which fire at different rate at 300 to 600 beats per minute. So if we talk about SA node, which fires at 60 to 100 beats per minute, right? So SA node will be depressed in these patients, right? So then we'll have the AV nodal block, just say when it is 2 to 1. So if an ectopic focus is firing at 400 beats per minute, so it will be 200, right? So ventricular rate will be 200 when block is 2:1. Where if the block is 3:1, right, so the same rate goes to 133, right? So if we divide 400 by 3, we're going to get this rate. If block is 4:1, we'll have the rate that is 400 that is 100 beats per minute, right? So because the ectopic foci fire at variable rate, right, sometime at 400, sometime at 500, 300, so AV nodal block will be variable, right? Then the ventricular rate will be variable, right? That's how we're going to get the irregular pulse, right? So we're also going to get this type of pulse in multifocal atrial tachycardia, which is seen in the COPD patients, right? So atrial fibrillation is type of tachyarrhythmia in which heart rate can touch normal, right? In the rest of tachyarrhythmias, we see the heart rate do not touch normal. So atrial fibrillation is a type of tachyarrhythmia in which heart rate can touch normal, right? So because of twitching of the atria, there can be stasis of the blood in left atrial appendage, right, and that lead to clot formation, right? Okay, so patient is going to complain of sometime we don't patient have subclinical AFib, right, atrial fibrillation, that is mostly seen on intracardiac monitoring devices, right? So those patients who have the symptoms, these include palpitations, dyspnea, dizziness, faintness, syncopal attacks, and irregular pulse, we're going to find on examination, right? And we will find the absent A wave on JVP, right? So A wave is because of atrial contraction, right? So we'll have this small C wave here, right? This is A wave, then we'll have this C wave, then this descent is called as X descent, then we'll have this venous filling, right, V wave, and then we'll have the Y descent, right? So because the atrias are not contracting basically in this condition, atrias are just there's fibrillatory waves in atria, right? So that's why we're gonna the A waves will be absent on JVP in these patients. If we get the ECG done, right, so heart rate will be more than 100 beats per minute, so complexes will be narrow, right, and P wave will be absent. Instead we might get the F waves, right? These are fibrillatory waves like this, okay? So this is called as F waves. And sometimes in lead V1 we might see the very those like fluttering waves, right? Fluttering waves in lead. So this should not be confused. So if we get the irregular pulse, right, and lead 2 is having F waves, right, oscillating waves, so we're gonna call it as atrial fibrillation, right? So irregular rhythm there will be. So how we're gonna treat this patient? So this treatment depends on the whether the patient is having the paroxysmal AFib, right? So that means the patient is having acute atrial fibrillation, right? Or if the patient is having long-standing, persistent atrial fibrillation, right? That means the chronic, or sometime if the patient is having episodic episodes, right? So episodic atrial fibrillation. So if you can see here, there is no P wave here, right? So in this patient, this is a T wave, so there is no P wave here, right? We're not gonna find any P wave in this patient. Instead we will get the fluttering waves there, right? So the rhythm will be irregular. So you can see here. So in the calculation of the heart rate, I have defined this how we're going to calculate the heart rate in atrial fibrillation patients. So you can go back to my previous video in the basics of ECG. I have described how to calculate the heart rate in atrial fibrillation patients. So now let's move on to the next page and let's see how we're going to treat this patient, right? So for treatment of acute atrial fibrillation, right, paroxysmal atrial fibrillation, so we will have to resuscitate this patient, right? And then we have to, the anticoagulation basically depends if the patient is having atrial fibrillation for more than 48 hours, right? So we're going to anticoagulate this patient, and then we will control the rhythm in these patients, right? So if patient is having episode less than 48 hours, so we can go for the rhythm control in these patients. So basically treatment is dependent on the rate control and rhythm control, right? So for rate control, we'll have the drugs like beta blockers, right, and calcium channel blocker like ismolol and verapamil. We're going to use this for rate control in these patients. And the second line is digoxin and amiodarone in these patients, right? So for rhythm control, we can use the ibutylite IV for rhythm control in these patients. Other drugs which can be used is amiodarone and procainamide, right? So ibutylite will be having 60 to 70% efficacy, and amiodarone will be having the 50 to 60% efficacy, and procainamide will be having 40 to 50% efficacy for rhythm control, right? So if the patient is having symptoms for more than 48 hours, we will anticoagulate this patient, and then we will control the rhythm, right? If patient is having symptoms for less than 48 hours, we will straight away go for rhythm control. There is no need to go for the anticoagulation, right? So for previously warfarin was used, but now we will have the direct oral or novel oral anticoagulants available, like I will have the rivaroxaban and dabigatran, which are available for treatment of these patients. If any patient is having chronic kidney disease, so we can use the apixaban for that. Apixaban, right? So rivaroxaban is basically the direct factor 10A inhibitor, and dabigatran is thrombin inhibitor, right? So these are the two drugs which can be used for the anticoagulation if the patient is having symptoms more than 48 hours, right? Okay, so if these things fail, we can go for the DC cardioversion, right? So it should be synchronized, and we can give the 150 to 200 joules of shock in these patients, right? Okay, the next thing is that if the patient is having chronic atrial fibrillation, right? So for chronic atrial fibrillation, we will have to just control the rate in these patients, and they should be taking the anticoagulation lifelong, right? So we will have to control the rate with beta blocker or calcium channel blocker, and we have to anticoagulate this patient lifelong. There is no need to control the rhythm in these patients, right? So we will have to give the NOAC in these patients, like apixaban 15 mg OD, right? OD dose is given, right? For episodic type of atrial fibrillation, these patients should have a pill in their pocket, that is flecainide. For initial, when we start the flecainide, we'll have to give the beta blocker when they these patients are having the symptoms of atrial fibrillation. So in hospital, we have to give the beta blocker, and then 1 to 2 hours we have to give the flecainide 100 to 200 mg, right, orally. So if the symptoms get control, so they can go home, and this atrial fibrillation, this type of episodic atrial fibrillation can be treated with beta blockers first and then flecainide, right? So in these patients, we are going to ask them to take beta blockers when they have onset of atrial fibrillation, right? And then 1 to 2 hours after beta blocker, they can take flecainide 100 to 200 mg, right. So for if duration is unknown in acute patients, right, those patients who present with acute atrial fibrillation, so we have to calculate this score that is called as CHADS VASC score, right? So this CHA2DSVASC2 score, right? So we have C stands for congestive cardiac failure, H stands for hypertension, age if it is more than 74, there are 2 marks for that. If patient is having diabetes, right, or S stands for stroke or TI like event, and vascular disease, if patient is having prior MI or peripheral artery disease or cabbage, so 1 score for that. Age if it is 65 to 74, 1 score for that. And sex category, right, that is female, 1 score for that. And if score is this is the previous guidelines. Now the guidelines say that if the patient is having, if there is a female patient is having score more than or equal to 2, we have to give the anticoagulation to these patients. If there is a male patient having score more than or equal to 3, we have to give the anticoagulation to these patients, right? So that's all about the atrial fibrillation, right? So I'm going to discuss about the atrial flutter in the next video. That's all for today.